Dr. Digvijay tell us about intermittent divergent strabismus.
Thank you, Professor Rohit, for having me as a part of your IC, and it's great to be presenting again in AIOC. So I'm going to talk about intermittent divergent squint, and I think most of the history Dr. Ankur has covered up. It's somewhat similar for this as well. The things in the workup that we have to look at primarily are what is the refractive error, is there any anisometropia, is there a dominant eye, how is the deviation for near and distance, is there a difference in terms of the near deviation after you do, you give a +3 diopter lens and relax the accommodation, or if you do a patch test, is there a pattern, is there any lateral incompetence? How is the fusional control overall? And in terms of stereoacuity, how is the stereoacuity of the child, both up to the stereopsis as well? Because they will often have simultaneous macular perception, BSV, but the stereoacuity is what starts to get affected first. And based on this, you will make a diagnosis. Is it a basic type of intermittent exotropia where the near and distance deviation is similar? Is there a convergence insufficiency type where you're going to get more deviation for near than distance? Is there a divergence excess type where there's more deviation for distance than near? And is it a simulated divergence excess type where, after doing a patching for a long time, the tenacious proximal fusion breaks and then you actually get a same value for near and distance. So based on that, and this becomes important because it changes our management a little bit later down the line. In terms of the therapies that we have, there are two options. You've got non-surgical and surgical. Non-surgical is optical therapy. It is therapy in the form of certain exercises. It is therapy in the form of prisms. And this maintains the sensory status of the eye. But the definitive treatment to correct the angle is actually the surgical therapy. So optical treatment, you want to give the optimal refraction because you want to have the best images in both the eyes so that it fuses the image. And in myopia, we want to give a full correction. You can give a slight over minus as well, though beyond that it causes asthenopia if you do an over minus, which is beyond 0.25 or 0.5. But generally, a optimal correction there. For hypermetropia, give an optical correction. Optimal correction. If there is a high AC by A ratio, you could undercorrect slightly. You want to give in presbyopia, you want to give the lowest near plus that you can give, and sometimes you give bifocals in the form of minus segments below or above based on whether it's a convergence insufficiency type or a divergence excess type of exotropia. So these are all, you can play around with the optics. Prisms are used in the interim to help children fuse. These are based in prisms. They can also be used in the form of exercises that there to stimulate the fusion, and these of course are essentially there for smaller angles. You can't correct a very large angle with these prisms because then it affects the quality of vision and it will break up even more. For orthoptic treatment, that is I think very popular in the form of convergence exercises, synoptophore based exercises, and now a lot of computer based exercises that are there. These generally work as supplement, increase the control, but they're not going to change the basic deviation. So they're basically more like a support treatment that you can add along with it. Surgical treatment is where it primarily comes in, and we do a surgery basically to get a good fusional control, to ensure that this binocularity is there, and to correct the angle. And it depends really on the age, the amount of angle, and the squint, the type of squint. Surgery is indicated in cases where either you're going to have a deviation for a large part of the day, there is an effect, it's affecting your binocularity, it's getting worse, the basic deviation, the Newcastle score is high, which is again a sign of how good the control is, or you're getting a secondary convergence insufficiency. So these are the cases when you want to operate. When do you want to operate? Literature is mixed up. There is early surgery, late surgery. Everybody has advocated different things. Generally, I look at it individualized. We try to see if the child can get visually mature. That is better because and if the stereoacuity is maintained. But yes, of course, if one of the indications gets hit, then even at a young age we will operate. And in terms of the choice of surgery, in adults we typically would do a recession resection. Again, that would depend upon, it could be unilateral or bilateral. There are advocates for both. Generally, a unilateral works well. In children, we do a symmetrical bilateral kind of a recession resection, and it would depend also upon what type of exotropia it is. So these are the basic parameters to look for before you decide your surgery. Lateral incompetence is something we should check for because we need to slightly undercorrect our surgical dosage when we are doing that. And options are recessions of the lateral rectors, resections of the medial rectors, or a recession resection, and you could use either, again depending on the type of squint that there is. And unilateral versus bilateral. Unilateral, generally in adults we are using bilateral in children because it's symmetrical, but you could choose either, and results are almost similar. Success criteria: if you get an optimal correction or even a slight overcorrection is acceptable. You should have binocularity, you should have good fusional control, and these are the kind of primary criteria that you're looking for in terms of the outcome. For undercorrections after surgery, if you could do certain exercises for a small undercorrection. Sometimes you would have to go in and revise or do a second surgery. That's there. You can use prisms in the interim period, and of course, over time, you adjust your surgical dosage also based on how your results are coming. Overcorrections, we do aim for a little bit of overcorrection in adults, not so much in children, but again, overcorrections are dealt with either in the form of initially managing with prisms temporarily, but if there is a large overcorrection and you've developed an esotropia, you will have to go in there and operate again, and you don't want to wait too long in visually immature children. So I'll just show a few cases. So one optical correction is correcting this intermittent exotropia very easily. You can do an R&R procedure in an adult, as you can see here in this adult patient. In children, we do a bilateral surgery or a bilateral recession, but again, you could choose, and particularly if there's a pattern or A or V pattern, then you want to combine it with your obliques in both the eyes, so their bilateral surgeries work well. Bilateral lateral rectus recessions. Again, you can correct the pattern as you see in here. That's the oblique being operated along with the resection procedure. And for small squints, you need to first figure out why is somebody breaking into a small angle squint. There may be some oblique or something else along with it, but you can again get away with a one muscle surgery. And if you get an overcorrection, this does happen. So this was an exotropia in a kid that I saw in IXT. We operated. He landed up with an esotropia, which was a little bit beyond what we wanted. So in the interim, we gave him some prism glasses. And over a period of 1 year, as you can see, he became quite ortho and doesn't need them anymore. So you need to learn how to manage those as well. Thank you.
Thank you, Dr. Digvijay. So we can take any questions or a few points of discussion. At a fault of sounding repetitive, again, refraction we come back to. Refraction is the sheet anchor of any treatment for strabismus, particularly comitant strabismus. We talked about accommodative esotropias in needing age-appropriate cycloplegic refraction to manage and correct for the accommodative esotropia component. For intermittent divergent squints, it is the fusional vergence mechanism that is active. So we are seeing binocularly. And that's why our eyes, which have a tendency of esophoria in young childhood when we are hyperopic, and exophoria as we grow older and the orbits become formed and the eyes actually get an outward drift. So because of that, the fusional vergence is preventing all of us from turning from an exophoric to an exotropic person. So again, the management of intermittent divergent squint becomes increasing and improving first the fusional vergence mechanism, and then subsequently think of how much the patient is breaking, what is the basic angle. Dr. Digvijay pointed out a very, very important fact. In small angle exotropes, please find out why the patient is an exotrope. We know that a lot of us may have an exophoria of almost 25-30 prisms, yet we fuse, yet we are well aligned throughout the day. Then why is a child with good accommodative reserve not being able to fuse, not being able to control 20-25 prisms? And that is because he may have either an inherent fusional mechanism problem, so outcomes may be poorer in those cases, or else again you look for oblique overactions, you look for some reason why the child is breaking intermittently, and that is preventing his stereopsis and binocularity from developing. So we have John Peter Sante from Denmark. Thank you for being here. And yes, you have a comment or question?
Yes, thank you very much for a very nice talk. I really like that.
Thank you.
Do you ever use Botox for convergence insufficiency patients? Have you tried that?
No, I have not used Botox usually for these convergence insufficiencies. Mostly I've kept that either for esotropias, in children, or in terms of, paralytic squints. But so far I haven't had. Have you had any?
So no, we also haven't treated acute comitant esotropias with Botox. Although, we generally operate them for surgery. Although there are a couple of good reports with a lot of data now on the use of Botox in intermittent in acute comitant esotropias.
Yes, so I was looking at CI, convergence insufficiency. And I think the problem with the CI is that it's a problem who gets back and back to us. We treat them, and problem comes back, and we never get rid of these patients. So we don't want to do surgery every time. And some of them will do well, like you say, with the prisms. Some will do well with convergence exercises, but you still have a group where nothing works. How can you help them? You don't want to do surgery every year. So in Copenhagen, we tried to study the Botox in one lateral for CI, and we give them 2.5 units and wait. And usually, many of these patients have been symptomatic for years. They haven't read a book for years. You give them one injection of Botox, and after a week or two, they call me back and say, "Oh, I can read books again. I can read books. I begin studying university again." And the funny thing about Botox for CI, it only works chemical 3 months. We know this. But for this, maybe they come back to a range where they confuse again. So this actually lasts maybe for 6 months and even 9 months for if you just give one Botox injection to the lateral rectus. So now we looked at, we just published last year a group of treatment refractive patients. So CI patients, nothing worked, exercises, prisms, and we didn't want to do surgery. So we gave them Botox. And we found that more than 60% were happy doing well with Botox for one injection. And now we have a cohort of maybe 30, 50 patients coming back every year having Botox, one lateral rectus, and it lasts for not the first time maybe 4 or 6 months, next time maybe 6 months, next time maybe 9 months. So they come back, they call us and say, "Okay, I can't read again, can I have another Botox?" "Yeah, sure." So we have every month a Botox clinic. They come in, have a little dose, and go home again. And they read and keep perfectly well.
So what is the mean age of these patients that you have managed for CI?
So, well, all age groups. We also have children down to 12 years of age we treat. But
predominantly must be the older age group where they are kind of breaking for near, or?
I think we have all age groups.
Because children would tend to do fairly okay with exercises, but yeah, with the older patients, it can become a challenge. One, because they anyway press biopic, so they are not comfortable doing the exercises.
Yeah, and over-minus doesn't work in elderly either.
Yes. So great, thank you, John. Thank you very much.
Very quick and keep the patients happy.
Yes. Dr. Laila, just we'll have a question and then we'll move on to the next.
From what I understood, you're doing a lot of Botox for these convergence insufficiency. So I would like to know how many of them completely recovered? Fusing? Never. So it has to be repeated.
Yes. So it weans off, but we don't understand why, because when we measure them, the measurements are always the same, but they're happy, and they say, "I can read again," and the measurements are still a little exo, but they're fusing.
Thank you.
I think what we do, what we understand, we weaken the lateral, and we just give them a little push inwards, and they can keep working their time, and then with the shot, we give us a little more.
Thank you.
Alternate the eye when you're injecting the Botox.
We usually give them non-dominant eye, but
Yeah.
I think you can do either.
So I would now thank you.